Hey guys, Dr. Ash here for intracranial regulation topics. We're just going to go ahead and get down and dirty, get to it. As most of you guys know by now, these videos are chopped up for your learning pleasure in very small increments, and this is going to be just the exact same. Okay, I'm not here to bore you all day long with the differences in intracranial regulation. Also, remember, we're always going to go by what it is, what it does in the body, our top signs and symptoms that were associated with it. What are we going to do about it from a nursing perspective? There are a couple of drugs in here that we're going to talk about. And then, of course, we're going to talk about some labs associated with some of these. Okay. Reason why I like intracranial regulation topics. Well, I'm not a big brain person, right? I have a big brain, but I'm not into neurological stuff quite so much. But I will tell you from a nursing school perspective and from the NCLEX perspective, neurological almost always means there's some sort of respiratory assessment happening in there. Okay, level of consciousness and respiratory assessment. So let's go ahead and get this party started. Let's talk about general assessments first. And I don't really want to bore you with the normals, but it is a good idea just to kind of review some of the normals, because it's hard to know what is abnormal until you know what normal is. So we just wanted to compare and contrast here, normal versus abnormal, when we talk about general symptoms. So we know that our pupils should be equal, round, and reactive. However, very abnormal would be fixed and dilated. That's actually a neurological emergency and should be reported immediately. Motor, that's just our movement. So tone, strength. Anytime we have two arms, two legs, two eyes, two ears, we compare the sides. So we want to make sure they're equal on both sides and the movement is purposeful. Now, for the abnormal, we talk about decorticate and decerebrate posturing, okay? And this all just has to do with, do the arms curl up towards the chest in the middle while the legs extend, or are the arms and legs both extending? And so just understanding not really the difference between the two of them, but really understanding that posturing is bad. Okay, if a patient begins to posture, that is almost as much as a neurosurgical emergency as the pupils being fixed and dilated. But definitely posturing is a decline in brain function. Okay, so posturing is a decline or a worsening in brain function. All right, let's go to the cerebellar part of the brain. The primary thing, the brain is responsible for a lot of different things, but we are focusing just on these intracranial issues. Romberg's, okay, the whole purpose of a Romberg's assessment is to look at balance and posture, and it's this fancy word called proprioception. And basically, the only thing that proprioception means is that I have an awareness of my surroundings and what's happening with my body when my eyes are closed. When I have an issue with it, there will be a loss of balance. So a positive Romberg's would mean that I have lost my balance. The test is done with the eyes closed, arms are out to the side, feet shoulder width apart. What happens when you close your eyes? Okay, so this is a proprioception problem. Okay, proprioception problem. Our reflexes, we have a couple of here. We have the Babinski, or also known as the plantar reflex. Now, as an adult, anybody above the age of 2, actually, there should be some sort of flexion of the toes. However, abnormally, again, after the age of 2, would be a fanning of the toes. So we don't really want that fanning and spread out toes. We definitely want the flexion of the toes in anybody over the age of 2. Corneal reflex just means that if I stimulate the eye or wipe a cloth on the eye, that there's a blink reflex. Of course, if there's no corneal reflex, that's bad. Same thing with a gag. When you stimulate the back of the throat, there should be like or a gag sensation. No gag equals a big time problem. And then last but not least, we have the Glasgow Coma score. Now, most of the tests that I've seen, that I've been a part of, NCLEX testing prep, etc., they typically give you the Glasgow Coma score scale, Glasgow Coma scale, okay? Because it is almost impossible to memorize those unless you just like have all the free time in the world and you want to do that. So you should have some sort of access if you encounter it as a test question, but normal is about 12 to 15. I like to tell people that my chair can actually have a GCS of 3 because there's no verbal response from a chair, there's no eye opening from the chair, and there's no motor response. And those are the 3 things that a GCS assesses: motor response, verbal response, and what do the eyes do in response to certain stimuli. Typically, we say a GCS of less than or equal to 8 means that they are in a coma. Okay, so less than or equal to 8, patient is in a coma. So vital signs, what we find is some very distinct vital sign changes that happens only in the neurological system. Blood pressure, we have something called a widening pulse pressure. That means your systolic or your top number of your blood pressure and your diastolic or your bottom blood pressure numbers get further and further and further and further apart. Okay, that is widening pulse pressure. So if I have a patient that's 120 over 80, then they're 130 over 72, and then they're 140 over 60, 150 over 30. That is a widening pulse pressure and typically indicates that the intracranial pressure is going up. Okay, so a widening pulse pressure. You're in nursing school. I hope if you're watching this, you want a nursing perspective. And so what this is going to look like is a set of vitals, and you notice the blood pressure just gets wider and wider and wider. I'm not going to ask you, is it a widening pulse pressure? I'm going to want you to identify that it's widening, and then I want you to understand that that probably means this patient's intracranial pressure is elevated. All right, temperature increases are going to happen for 2 reasons in neuro. Number 1, either there's a metabolic rate of the brain, something's happening in the brain, seizure activity, could be trauma, could be bleeding that causes that temperature to rise rapidly, or if it's a very slow, progressive increase in temperature, that usually means there's an infection happening in the brain. Okay, last but not least, we have respirations. Remember, I told you neuro is easy because we need to do a respiratory assessment. And so the Cheyne-Stokes breathing, that's the periods of regular breathing and then becoming apneic or no breathing at all. Metabolic dysfunction causes some respiratory issues. Neurogenic hyperventilation, that just means they're breathing fast or they're tachypnic for some reason that's going on in the brain. And then we have apneuristic, and that just means apnea, right? This is just a fancy term for periods of having apnea or no breathing. So again, remember the blood pressure, we have the widening pulse pressure for intracranial pressure. Respirations are going to change because that's where the center, our brain, we have a brain center specifically for respirations, specifically for temperature control. So that's why these vital signs are the most important when it comes to neurological. Let's go over to functioning just for a minute. And the reason why we go over function is because if I have a brain injury of the frontal lobe, it may impact my emotions, my concentration, and the ability to produce speech. So the reason why the function review is important is because if there is a head injury, and that's why it's starred here at the bottom, if there's a head injury, we need to know what area the head injury is at. When we know where the head injury is at, we know the expected findings, right? So if I've hit and I've damaged my frontal lobe, I have problems with morals, emotions, reasoning, judgment, concentration. This is where I find Broca's area, which means I have trouble with speech production. If I were to get hit or damage to my parietal lobe, that's where my sensory information is. It's my speech or my hearing, my vision, my taste, my touch, my pressure, my depth perception. Do I understand how far away that curb is in front of me? So if I have damage to the parietal lobe, these are the things that will be affected. The temporal lobe, probably the easiest because it's by the temple of your head. That's close to your ear, so it's an auditory center. It's also responsible for memory. This often is called, or you may see this in a nursing situation as damage to the Wernicke's area. Okay, Wernicke's is responsible for speech comprehension. So Broca means I have trouble speaking, but Wernicke's means I have trouble understanding what's being said to me. The occipital lobe is responsible for vision. And of course, we have the limbic system. And this is just easy to remember because we have what's called a primitive brain. The limbic system is our brain back when we were cavemen and we had to fight a saber-toothed tiger for dinner. And so it's very much a survival mode. It's very much a part of your learning and your memory. And so the limbic system can be very important when it comes to a lot of this neurological stuff, because the primitive brain is going to be the last part to protect you from any sort of oncoming threats. All right, just a couple of diagnostic testing, because we do love to ask you about diagnostic testing. Remember, this is number 4 under my 4-step formula. So number 4 would be any diagnostic tests or lab procedures. So diagnostic tests, of course, we can do x-rays or radiographs, seems to be the fancy name that nurses like to use on tests. And that just looks at structures. Is there any fractures? Are there any obvious defects in the skull or the brain? Then we move on to a CT scan, which is technically called a computed tomography. That is a more defined x-ray. So this is like radiation times 1,000. It's very quick. It's very good for identifying bleeding, lesions, swelling, if they've had a stroke, especially hemorrhagic stroke, hydrocephalus, water in the brain, which we'll talk about, atrophy, where the brain begins to shrink, typically with age changes, and if the brain shifts at all. Because what happens is if I have a brain injury, sometimes it will shift my ventricles. Okay, so we know, not to get too A&P on you, that the brain has 2 ventricles. It has 2 hemispheres. And so we look to see if that's equal. Remember, anytime we have 2 of something, we look for equality and seeing if it shifts. Now, the CT scan is probably the most common thing that gets ordered if I'm worried about any neurological changes, because it can tell me very quickly, and you see the list here, it is very thorough on what it can tell me what's going on with my patient, and it's very quick. So a CT scan, bing, bang, boom, in, out, less than 5 minutes, and life goes on. MRI is magnetic. That's in the name, magnetic resonance imaging or something like that. I don't know. I, for one, am not like this, diagnostic guru. So MRI, I just know magnets. Magnets are bad for certain things like metal and pacemakers. So please make sure that your patient does not have any metal on, in, or around their body, because it will come flying out from this high-powered magnet. And of course, magnets will stop a pacemaker. So please don't put a pacemaker patient into an MRI machine. But MRIs are very good at vascular. So it looks very good at arterio and venous flow through the brain. In fact, it's not on this particular lecture, but AV malformations, arteriovenous malformations, are often diagnosed with MRIs, but that's outside of the scope of what we're talking about today. And then lastly, we have the lumbar puncture. So this, also known as LP. This is done at around L3 to L4, and it is purposeful in getting a sample of cerebral spinal fluid, CSF. So it will give a sample so we know if they have like meningitis or they have something else going on in their spine. The biggest thing to remember here is if I have a patient that has increased intracranial pressure, I do not want to stick a needle in their back and start to drain cerebral spinal fluid. What happens is this: I have a lot of pressure in my brain. I now have had a needle inserted to drain some of that CSF, and it's going to drain too quickly. That pressure is going to drop too quickly. And when your pressure drops too quickly, the brain is going to push down on the spinal column, which is also called herniation. And when herniation happens, death happens. Okay, so brain herniation is bad, and it will happen if lumbar puncture happens to an increased intracranial pressure. Okay, so an ICP patient should not get a lumbar puncture. It will cause brain herniation, which will cause death. All right, let's talk about the unconscious client for just a second. So these are obviously we're into our disorders. So what is it? It's a depressed function, and they don't respond to stimuli. It's just that simple. Okay. A lot of times it's caused by shock or hemorrhage or trauma or tumors, or maybe they've done too much drugs, right? They've had a little too much to smoke or a little too much to drink. So toxins can cause unconsciousness. So again, findings, this is very simple. They're not arousable. They don't respond to painful stimuli. There may be changes in respirations where they go down. So we would expect a drop in respirations as well as reflex activity. So of course, our interventions assess airway all day long, vital signs, lung sounds, head of the bed up, because the unconscious client may or may not be able to protect their airway. Okay, and what I mean by that is if they go to vomit or they have a lot of secretions, they are at risk for aspiration pneumonia or possibly even choking to death. So of course we want the head of the bed up, which also means we don't want a Trendelenburg position. Okay, that's when the head's all the way down and the feet are all the way up. Absolutely not on our unconscious patients. Increased intracranial pressure. Now, you've heard me say those key words a couple of times already. What is it? It basically just means that my body's not absorbing cerebral spinal fluid like I should. And so my pressure is going up and up and up because there's excess fluid. So it's either some sort of impaired circulation, inability to absorb. It will actually change how your neurons function and would even cause death if it is left unchecked. Okay. Causes of this, again, trauma, tumors, hemorrhage, excess fluid, inflammation, swelling, all of the above. What you're going to find, and this is the classic symptom of increased intracranial pressure, are changes in the levels of consciousness. I will say that again. The number one assessment thing that you will see in increased intracranial pressure, or ICP, is a change in consciousness. Okay. Also a headache. Vital signs changes known as the Cushing's triad, right? It changes our respirations, decreases them, it decreases our heart rate, and it decreases the blood pressure. All right. Again, don't forget that widening pulse pressure that happens. Interventions. Oh, imagine that. I'm going to assess respirations. We want to avoid morphine because we don't want to sedate the patient. Okay. The sedation is going to hide what's really going on. If I have an increased ICP, and I know changes in level of consciousness are my number one indicator, why am I going to sedate them with medications? It's just going to change the LOC. So we don't want to do that. We want to prevent any sort of stimulation, no shivering. We want the lights down low. We want to minimize noise. We minimize distractions. We minimize visitors, okay? Because the more activity that happens, the higher that pressure goes in the brain. These are patients that we don't want to be coughing continuously. Coughing increases intracranial pressure. So literally stop any sort of stimulation, head of the bed, 30, 45 degrees. And typically these patients will be on a fluid restriction because they've already got enough pressure. We put more pressure using more fluid on there and we've got a problem. So fluid restriction of about 1,200 milliliters. Now, this is where the medications come in. We've already talked about avoiding the narcotics because we don't want to mask any symptoms, but the other medication that we give happens to be a diuretic. It is also known as an osmotic diuretic, and that is mannitol. Now, here's the connection I want you to make. All right. Mannitol is a diuretic, yes, but it is only used for brain-related diuresis. Okay, so mannitol is an osmotic diuretic that works in the brain, works for intracranial pressure only. Now, here's another connection I need you to make. Because my patient with increased ICP has changes in their level of consciousness, if I give mannitol, I expect that level of consciousness to improve. Okay, let me say that again. If I know, because here's my findings, I told you the number one indicator of an ICP issue is the change in levels of consciousness. I'm going to give mannitol. I make the assumption, or what I expect to happen is their LOC improves. Okay, so mannitol should improve the level of consciousness. All right, head injuries. This can be trauma that causes damage to the brain. Again, respirations are a big thing. All right. Head injuries can cause seizures. It can cause bleeding. It can cause bruising. It can cause collections of blood, such as hematomas. It can cause increased ICP. Okay, so head injuries are bad. A concussion specifically is just where the brain gets jarred, may or may not have a change in consciousness. That will tend to change the behavior or personality. Okay, because again, that frontal lobe usually gets involved. So changes in behavior or personality. Sometimes the effects are seen for many years. Okay, so concussions, they may look okay, they may be okay, but it is a very long-term kind of thing. Immediately after a concussion, we don't want to hear the patient say, I'm going home and going to bed, I'm so tired. Okay, so sleepy is a red flag in an immediate concussion. Contusion would be bruising of the brain tissue. And then of course there's skull fractures where the bones of the skull are actually literally fractured or broken. A couple more things in head injuries. We have the epidural hematoma. That means there is a blood collection that happens between the dura and the skull. This can be the most serious because oftentimes it can be because of an arterial bleed. And we know about arterial bleeds, you can bleed out from an artery. A subdural hematoma is below the level of the dura, and that's usually a slow bleed because typically it's a venous bleed. Intracranial hemorrhage just means that a blood vessel within the brain has ruptured or broken and blood is leaking into the brain. This is also known as a hemorrhagic stroke if you have stroke-like symptoms. And then there's the subarachnoid hemorrhage, which just means it's a bleed in the subarachnoid space. A lot of times it can come from head injuries or traumas, motor vehicle accidents, football accidents, things of that nature. So some general interventions for all of these head injuries, okay? So there are multiple head injuries, but basically our outcomes are going to be the same. Respiratory status all day long. The other thing we have to monitor for is clear drainage from the nose and ears. Clear drainage. Clear drainage could be a sign that there is a break or skull fracture, and then there's a leak of cerebral spinal fluid, okay? When it comes from the nose, I like to say this. CSF has glucose, but snot does not. So cerebral spinal fluid has glucose, so you can test it. It has a sugar level, but regular snot from the nose does not. Okay, so that's a good way to remember that CSF or cerebral spinal fluid contains glucose, but oftentimes it'll either dribble from the nose or it will leak from the ear. So you can test it for glucose. The other thing you can do is what's called the halo, where you put a drop on a piece of gauze and it actually creates a yellow halo. So we always have to make sure that it's not CSF coming from either holes. All right, head of the bed up 30 to 45 degrees. And of course, we want to avoid neck flexion or any sort of excess activity of the neck, because that's just going to increase pressure in the head. Hydrocephalus, this sounds really bad, but it really means waterhead, y'all. If you look at hydro means water, cephalus means head, so it's waterhead. Basically, it's an imbalance of the ability to produce and absorb cerebral spinal fluid. obviously, right? So we have too much of a production and our body can't absorb it. Oftentimes this happens again because of some sort of trauma to the brain. There might be infection, there might be a bleed, or there might be just some malformations. We talked about AV malformations earlier. This is common in children. Very rarely are you going to see this in an adult unless they've had a traumatic brain injury. Okay. So our findings for infants, the head is bigger. So we have an increased head circumference. You may notice the suture lines of the skull are separating. There's actually space between those sutures where there shouldn't be. Sun-setting eyes. That's where their eyes are down. They're like half closed and their eyes are looking down into their eye sockets. Very irritable and a high-pitched cry. Like I cannot say that enough. A high-pitched cry in an infant usually means some sort of neurological disturbance. Children, they tend to be more irritable. They'll complain of a headache that happens to be a little worse in the morning when they first wake up, some nausea, vomiting, and ataxia. Basically, they just stumble or they're very wobbly. They have issues with balance and coordination. Brain tumors. I think this might be, yeah, we're almost done here. Brain tumors. Basically, it's a tumor in the brain. It's really not all that exciting. Nothing too much happening here. I do know that the infratemporal or the back 1/3 of the brain is probably the most common site for brain tumors. They do account for the symptoms of increased intracranial pressure. So if my patient is displaying increased intracranial pressure, a brain tumor could be the cause. Headache that's worse when they first wake up, vomiting unrelated to any food intake, ataxia, again, that motor imbalance, and or seizures. Management tends to be surgery, radiation, and chemotherapy. Not a whole lot going on there. I do just want to mention very quickly that there is a little bit of criteria for brain death / organ donation because we are kind of in that brain injury intracranial issue. And so just so you know, a Glasgow Coma Score or GCS of less than or equal to 4 is criteria for brain death. And also the patient has to have a ventilator in order to breathe. So that's what vent dependent means. They have to have a ventilator in order to breathe, but they still have a heartbeat. So just keep that in the back of your mind if you should see that in your future. And then the last thing I want to talk about, and it doesn't really have to do with injuries, it's more from the perspective of well, wait a second. So what, I lost my train of thought there for a second. Sorry. So it's more from the perspective of diabetes insipidus and SIADH can actually come from either head trauma, having a stroke, or tumors. So that's kind of why it fits nicely into intracranial concepts. So I put this side by side because they are absolutely opposites. Diabetes insipidus has nothing to do with blood sugar. Diabetes insipidus has nothing to do with blood sugar. Okay. So DI is not enough antidiuretic hormone. Antidiuretic means I'm against diuresis or I don't want them to pee. So if I don't have enough of that hormone that says don't pee, they begin to dump urine. Okay, so this lack of ADH causes the renal tubules not to be able to absorb water. Again, trauma, stroke, surgeries can cause this. Polyuria, lots and lots and lots of urine. This is where the diabetes part comes in. And polydipsia, they're extremely thirsty in an attempt to get the water replacement to happen. Dehydration all day long. I'm not hashing out the signs of dehydration. You should know those already. Cannot concentrate urine. What does that mean? It means that my specific gravity is low. So low specific gravity, and I have hypernatremia. Okay. This is a classic example of why I don't like the term water or salt follows water or water follows salt, whatever that happens to be. Okay. Because when I am dilute, when I am concentrated, I am hemoconcentrated in the face of dehydration. Hemoconcentrated means my particles that float around in my blood, sodium, potassium, hematocrit, those are going to be higher, okay? Because when I have a cup of sugar in half a cup of water, I don't have enough volume to support all those solutes, okay? So low specific gravity, high sodium. What do? This is a hydration problem. So I's and O's, weight. We tend to want a hypotonic solution in order to drive the fluid back to where it needs to be. Oftentimes, these patients will get prescribed vasopressin or desmopressin. Vasopressin or desmopressin, okay? Same drug. Its intended purpose is to slow down urine output. It mimics ADH or antidiuretic hormone. Now, on the other side of the spectrum, we have SIADH, which is syndrome of inappropriate antidiuretic hormone. This is when we have too much ADH circulating around, and it ain't because we need it. Okay, so it is inappropriate. We have too much circulating. When I have antidiuretic hormone, it's telling my body not to pee. So what happens? I have fluid volume excess. Again, not hashing out those signs and symptoms again, but fluid volume excess all day long. Changes in mental status. Why? Because I told you a long time ago, sodium is a brain symptom. Okay, so anytime my sodium is off, I expect some sort of brain symptoms. So we're going to have low sodium because I have so much fluid volume that it dilutes my particles. Okay, this would be the gallon of water and still the cup of sugar. The cup of sugar in a gallon is diluted down. Same thing with your sodium and your hematocrit. It is diluted down in SIADH, which also means the urine specific gravity is going to be high. I told you these two are opposites, and I delivered on my promise. So again, this is a fluid thing and this is a sodium thing. So I's and O's, weights, safety, seizure precautions, and of course we are going to monitor for hyponatremia because that's when our brain becomes symptomatic. When it drops below 120, we become symptomatic. All right, guys, that is it for this video. I hope you found it helpful. Please make sure you like, share, and comment. Invite your friends, all that fun stuff, so you guys can learn all about intracranial regulation. And I will virtually see you in the next episode.